Hi, everybody, and it's really lovely to see so many people here this evening for the 6th annual lecture in our distinguished lecture series in what is now an established yearly event in the MICRA calendar. We're absolutely delighted to welcome Professor David Oliver this evening, speaking about a topic of great interest, increasing importance, and I know you've all come here to hear him. In a few minutes, I'll be handing over to Professor Neil Pendleton to properly introduce our learned and distinguished speaker. Tonight's event, I'm very pleased to say, is in collaboration with Manchester Metropolitan University, reflecting the tremendous commitment that our universities in Manchester are making to aging research. And MMU have co-sponsored tonight's event, so thank you very much to them. And just to say, if you're so inclined, if you want to live tweet the event or follow it on Twitter, our hashtag is Aging and Frailty. So for those of you who don't know me, I'm Debbie Price. I'm the new director of MICRA, having recently stepped into the rather large shoes left behind by Professor Chris Phillipson on the foundation that he and James Nasru and others have established, reflecting the world-leading research into aging that is going on here at Manchester. So here at MICRA, we are committed and convinced that developing interdisciplinary research is a key task for advancing work in aging. And UOM is at the cutting edge of these new insights. Many of you, of course, already know us through the excellent work that our manager, Jo Garsden, and her team do in stakeholder engagement, and especially in ensuring that older people are integral to both project design and project outcomes. I wanted to take the liberty as your host this evening to take 2 or 3 minutes to highlight some of the exciting work that's going on here at Manchester. In the last few months alone, we've been delighted to announce a number of large grants from Europe, from the research councils, and from other funders that we rather ambitiously envisage transforming the lives of older people through research and research translation. And these include the SenseCog project, led by Ira Leroy and Piers Dawes, which is working between medicine, sociology, health economics, and cognitive neuroscience, aiming to understand the relationships between vision and hearing and cognition in later life. We've got the Preventative project led by Chris Todd, a collaboration between health informatics and bioengineering with economics, medicine, health psychology, that is aiming to transform the way that people understand their own health. Sarah Lindley's new project, which I'm delighted to say is in collaboration with MMU and Salford, is looking at green infrastructure and is a collaboration between geographers, sociologists, economists, health professionals, and academics from the arts and philosophy, aiming to improve the lives of older people through scientifically evaluating the role of green and blue spaces and working to eradicate inequalities in how we access these spaces. There are many more recent successes, looking at social isolation among older people, working with Greater Manchester in their Ambition for Aging project, research on aging and migration, on pensions and other forms of social assistance, on social capital and inequality, on aging skin, on malnutrition, on crisis teams in dementia, macular degeneration, improving outcomes for older people with spinal trouble, on stroke. These recent successes contribute to more than 60 projects across the university that are breaking new ground in aging, pushing the boundaries of understanding aging in later life. Like Dave Lee's work, which was the first project of its kind to contemplate and thereby demonstrate that people in their 80s still have regular sex. Or our flagship project, Frail, led by James Nasru, which is transforming the way that we think about inequalities in later life. We have a substantial program of research under the umbrella of dementia at Manchester, ranging from biology and medicine through to health technology, treatment, management, and living well with dementia. I hope in that just a couple of minutes I've given you a flavor of what is happening here in aging research in this great and ambitious city. It's on that rather positive, I hope, and uplifting note that I'm going to hand the mic over to Neil Pendleton to give a very warm welcome to Professor David Oliver, who will be presenting on aging and frailty, game changers for our health and care services.
Can you all hear me? Yes, good. So I have the honour of describing to you David Oliver, which is, it's an honour and it's quite a challenging task. So I started by looking at what I could find out about David Oliver on the internet. And I started by looking at that great resource called Wikipedia. And in fact, there are 11 David Olivers on Wikipedia. One is an American athlete. Don't think that's David here. One is a flautist. No, don't think that's him. Ice hockey player, magician, possibly, and an R&B singer. But actually, the 11th one is our David Oliver here tonight. So he's got a page on Wikipedia, which is something quite unusual for geriatricians. So I've known David for some time. He's a geriatrician like I am, who's involved in healthcare of older people. I won't go too much through his past, but he's currently a geriatrician in Berkshire, at Reading, and he's also a visiting professor at City University, London, and a visiting fellow at the King's Fund. Between 2009 and 2013, he was the National Clinical Director for Older People at the Department of Health and NHS England. And he's currently the president of the British Geriatric Society, which is the national organisation and group where geriatricians and medical professionals interested in older age are members. He's also a weekly BNJ blogger. His blogs are well worth reading. And in the Health Service Journal, he's named as one of the 100 health service leaders in the country. So I think that's quite an achievement. I remember reading an article of his in The Guardian in 2014 called Older People Not a Burden. And that's quite an interesting article for two reasons. The content is interesting, and there's a very good photograph of David on the article, which, if you'd like to now, you can look up in Google. I won't tell you how he described himself when he saw that photo, but he might tell you himself. He has a number of qualifications and achievements. He has a large number of things you will know about him, but the one way he often describes himself to me is as a media tart, which I find quite interesting. Tonight he's going to talk about something that's being widely discussed around the world of health and social care, which is frailty. And he's going to talk to you about his vision of what's going on in frailty and what the current position and plans are for it. I'd like to welcome David to tonight's lecture. I'm sure you'll all welcome him up to speak. And thank you.
Thank you. And the sound's working okay for you all, is it? So what Neil didn't mention is the British Geriatric Society spring meeting is going on in Liverpool as we speak. It started this morning. And I had to do an interview on LBC radio at 2 o'clock about, have you seen the Ombudsman's report about premature discharge from hospital today? And the only reception we could get was on the banks of the Mersey. And right in the middle of this interview, the Mersey ferry started tooting its horn. So, but I do have strong connections with the area. I work in Berkshire now, but I'm Manchester born and bred. My parents were descended from Irish immigrants who'd changed their name, actually. My granddad and my grandma were from Ardwick and Ancoats. If you go up the road there to what used to be the Grosvenor Picture Palace, My granddad, Frank, was a projectionist at the Grosvenor Picnic Palace, amongst other things, in the days when they still used to play the piano during the movies. And both him and my uncle Ray was a nightclub entertainer around the working men's clubs of Manchester by evening, and worked at the British Airways ticket office near the Oyster House, you know, that some of you'll remember. I've got family all over Manchester. I admitted the first patient in the MRI casualty department when it opened in 1991, who was a poor 11-year-old lad who'd caught his willy in the trouser zip, as it goes. And my parents, Fred and Marlene, God bless them, who are 74 now, they live where Sharston Baths used to be. Do you remember the swimming pool there? And they do have a habit of turning up at my talks sometimes if I'm in Manchester, but they're in Spain at the moment, so I've been spared that. So I've got strong connections with the area, even if I'm down south now. Here's what I want to cover in the talk, really. A bit about population ageing, some key facts and figures. What the good news is about the implications for population health. A bit about the downside, including frailty. I'm not actually going to get into detailed information about frailty science and what it is and what it isn't, because it's a public lecture and I don't want to get too science-based. I would signpost to you a resource that's called Fit for Frailty. And Fit for Frailty, it's parts 1 and 2, and it's something the BGS did in conjunction with Age UK. So we've got lots of older people and their families talking to us about what frailty means to them, about the language they prefer to be used about it. So that's called Fit for Frailty. A second really good public resource, if you're interested, is that Age UK regularly have a fact sheet about ageing, health and care in the UK. They update the numbers and the references several times a year. And the final thing to mention is NHS England have a toolkit on frailty for primary and community care that is, again, very user-friendly and very readable. I'm going to flag a couple of other key references as I go through. But I'm going to talk about frailty, what all of this means for health and care services, and how we might need to change what we're doing. And what have I been talking about on the radio today? The Ombudsman's report about people being discharged either prematurely from hospital with inadequate support at home, and the carers and the older people not being involved. And of course there is the corollary of people being marooned in hospital, waiting endlessly for social care, which in my day-to-day, I look after a 28-bedded ward of frail old men, and I've got 8 of them at the moment who are absolutely stuck because of social care funding cuts, and that's the lived reality for many of us right now. So what might we need to do differently? What I'm not going to cover in the talk is loads of specifics about UK health policy, but I'm an ex-Department of Health civil servant. I work for the King's Fund. I write about health policy a lot. I teach health policy. I'm very happy to talk about policy as much as you like at the end, but I don't want to get mired in all the detail about NHS funding right now. I will give out contact details, and I assiduously write to people who write to me. And I'm on Twitter all the time, and I respond to tweets and so forth, as long as you're not too hostile. And if you want to know kind of most of my wisdom on this subject in one easy resource, I wrote this paper for the King's Fund with 2 colleagues called Making Health and Care Systems Fit for an Ageing Population, which is designed to be very user-friendly, very readable, full of practical, common-sense examples of how we can do things differently. It's free on the King's Fund website, and it comes with a free slide set all of its own. And there's been several King's Fund events we've put on all about frail older people. If you would like to know what's going on down in Liverpool, we've got 700 people at our 3-day conference. All day today has been about dementia and end-of-life care. And the hashtag for that, if you are on Twitter, is hashtag BGSConf, C-O-N-F. And we try and storify all the tweets. We might even try and get a bit of cross-linkage with the conference. But most of what I'm going to say you'll find in that paper there. So ageing, and I realise that in the audience we have some people who know more about population ageing science than I do, so bear with me if you're a bona fide expert. But people talk about the rectangularization of the survival curve, don't they? That people used to die in childhood or in midlife, often of single conditions, and then they'd have a few years of often not very healthy retirement and they'd die. What we've got more recently is an elongation of the tail of the survival curve. And I like my killer statistics, and something that's really compelling to me is when the NHS was founded, and you know the first patient in the NHS was a girl having ENT surgery at Trafford Hospital. If you go and look at the pictures, nearly half the population died before they got to 65. Nearly half the population. It's about 12% now. So the fastest growing demographic is the oldest old. And that single fact has changed, it's repurposed what health and care is all about. And that's kind of the theme of my talk, really. If you look at the projections, so I was 50 in January, and these days doctors aren't allowed to retire till they're 67. My dad was a consultant psychiatrist at Tameside General, and psychiatrists had special dispensation to jack it in at 58, so he did. Although my mum kept sending him back out to work because she didn't want him in the house, you know. But these days, we're going to have to work till we're in our late 60s. So within my career, this is what's going to happen. Right now, the average 65-year-old man in England will live 18 years, the average woman 20 years. There are major health inequalities, which I'll come on to. But it's going to be about 88 and 91, your life expectancy at 65 by 2030. And there are big implications there, not just for population aging, but the working age adult population to support care of older people and the workforce. So the anti-immigration zealots are actually probably risking depriving us of the workforce we need. It can't have escaped your attention that the NHS workforce crisis has been all over the news recently, that they've got the numbers wrong. We've got at least 25,000 nursing vacancies, 6,000 medical vacancies in social care. The care agencies can't source carers and so forth, okay? So it's not just about population aging, it's also about the workforce to support older people. But that's quite a stark demographic. If you were to look at some of the countries involved in the Arab Spring, for instance, you'd see a very different population pyramid with a predominance of younger people. Carers, family caregivers, really important to mention this right up front and centre because it's a huge part of my day job. We have open visiting on my ward. There's something called the John's campaign that you may have seen. So the carers are encouraged actively to be on the ward and to communicate with us in real time. There are 6 million carers for an older relative in the 4 nations of the United Kingdom. About 1.5 million of those people are over 65 themselves, and many of those carers are in poor health, and caring often affects their own physical and mental health. A surprising figure is that there are as many male carers over 65 as there are women, actually. So a lot of these carers are a good age themselves, and in my day job I will see this. And in fact, even when it's children, often now the adult children are past retirement age, okay? We think, according to a House of Lords report, we're going to run out of unpaid caregivers within the next 10 years. Demand will outstrip supply at the current demographic. And it's often the carers' stress and the carers' well-being that will precipitate admissions or make it hard to get people home or precipitate transition to a care. So not just tokenistically, but really trying to live the value, and comes back to what I was doing on the radio today, older people and their carers at every turn. So I make no apology for saying that. And by the way, Carers UK recently had a paper last week showing that despite the Care Act saying on paper that carers have statutory rights to support with system navigation, it ain't happening. It's tokenistic, and I was in the bit of the Department of Health that drafted that legislation. It's good legislation, but the money has to accompany it. So this is disability-free life expectancy. So my mum and dad are 74. They spend some of the week in Llandudno, they spend some of the week in Sharston. They still go walking around the Great Orme all the time. They love the theatre, because my whole family are from kind of, you know, amateur dram or nightclub entertainer type background. They always seem to be out the theatre. They're in Spain at the moment. They're still actually pretty active and independent, and we all know lots of people in their 70s who are very active and independent. We hosted a lunch yesterday for living past presidents of the BGS, and there's some brilliant examples of optimal aging amongst them. But on the other hand, we can't be in denial. People generally will have about 10 years of disability-free life expectancy at the age of 65. Okay? And you can see that very clearly here. For both men and women, you get about 10 years on average before you start running into difficulty. There's plenty you can do to modify that, by the way. We know from World Health Organization reports about half of all the poor health in older age is modifiable by, or at least attributable to, lifestyle factors like exercise and smoking and alcohol. So there's things we can do even beyond 65 to modify this, but that's the picture at the moment. I don't know where I sit with that because I'm an exiled Manc, but you know, Mancunians have some of the earliest rates of premature mortality in the whole of England at the moment. So emigrating to posh Berkshire may make a difference, I don't know. This is, when I say ADLs, for the non-kind of healthcare people, that's activities of daily living, okay? So people like the occupational therapists, the nurses, the doctors on the ward will be looking at things like washing, dressing, stair climbing, transferring on and off the bed, walking and so forth. Common instrumental activities of daily living. And what this shows really with age, from the English Longitudinal Study of Aging, is how independent people are with those activities. And we're blessed in the UK and Ireland because we have these big cohort studies and censuses and surveys. But you can see actually most people make it into their 70s without being dependent in one of these common activities of daily living. In fact, the Duke of Edinburgh was admitted to hospital a couple of times 2 years ago, wasn't he? I always have a bit of a laugh thinking about what would it have looked like for him, house, well, 12 houses, 100 staircases in each, personal care, footmen and butlers, wife 88 still goes out to work, and his ADLs would be things like dressing up in military uniforms and riding buggies and traps and whatever. But what you'll find is as people age, people do start to accumulate impairments in common ADLs, and we can't be in denial about that. Now, here's an interesting thing about the social care funding cuts. This is from Age UK analysis of the English longitudinal study of aging. So what you've got on these bars here is, are you impaired in 1, 2, 3, 4, or 5 common activities of daily living? And then do you get statutory social services support? Now, by the time you've got 5 impairments, most people get some statutory help, don't they? But there's a lot of people out there with 1 or 2 impairments in, say, walking or standing or stair climbing that get no formal help at all from the state. And so if any of you are interested in healthier communities, age-friendly cities, community assets to help people age well, this is where that gap is filled, and also with the role of the unpaid carers. And the social care, I said I wouldn't talk much about policy, but the coalition government in 2010 slashed something like 35% in the direct support grants to local government. Social care is not ring-fenced within local government budgets, and despite all the noise about the Better Care Fund, most respectable analysis would suggest that social care funding has been cut by about 30%, and giving a precept to a local authority that has low property values is not going to solve that problem. So that's getting worse at the moment, not better. So we shouldn't catastrophize about aging, and I think this is a really important message. If you look here at common killers over the previous century, so respiratory disease, heart disease, cancer, and so forth, cancer death rates haven't gone down because there's a lot of lifestyle-related cancers, okay? But the other common killers have declined dramatically. I qualified in 1989 as a doctor, and in the, say, early 1990s, it was very common for blokes of my kind of age and physique to be dropping dead from heart attacks. You don't see it now, because we've got much better at managing their blood pressure, their diabetes, their cholesterol, got better range of medications for preventative and long-term conditions management. And then when they do get sick, we do interventional heroic cardiology, whereas it used to be bed rest and a bit of aspirin and anticoagulation. In fact, during the junior doctors' strike, there are lots of tales around the country of people being pounced on by very senior cardiologists and whisked straight off to the cath lab. So actually it's a success story, not just for modern medicine, but for societal conditions, for workplace safety, for nutrition, for housing and so forth, and yet we tend to catastrophize about it. And I've written a lot about, I did a lot of the work on the age duty of the Equality Act in 2010. I've written a lot about ageist terminology, and I challenge the term bed blocker at every time I do media. I say, well, you're not called people bed blockers, and you've got to keep on chipping away. The conference I've just come from, I'm going back to, someone had analysed all the cancer reports from Irish newspapers, and the average age of the cancer patients in the stories was 27. You know, it's sexy and it's glamour if it's a young mum dying from breast cancer or something, but actually most people with cancer are older. And this is the kind of phrases you get. The grey tsunami washing towards us, the ticking time bomb of aging, the burden of aging, and you get the invisibility of older people, don't you? They're either skydiving grannies, Fuja Singh running the London Marathon at 102, David Attenborough's 90, isn't he? Isn't he marvellous, And do you remember Bruce Forsyth used to come out on Strictly and say, I'm not Doddery, I am not, So you're allowed to be seen in the public eye if you still look like a young person and function like a young person, or it's the Daily Mail victims of abuse and neglect, isn't it? Dignity for the elderly. And where do we get more realistic representations of an older person who's chugging along quite happily with 1 or 2 functional impairments, okay? And then you get this patient blaming, don't you, or person blaming the bed blocker, the social admission. So there's ageist values in our society, and they colour the values of health and care professionals, and they colour the language used. If you want a bit of fun, I wrote a blog for the BGS called The Geriatric Medicine Profanosaurus. If you've ever read Viz magazine and Roger Melly, the man off the telly, he's very sweary. And it was all about words and phrases like poor historian. Well, nobody says that 5-year-old paediatric patient is a poor historian. They can't talk any sense. But you get older people labelled as a poor historian, social admission. So we've got to sweep away those negative attitudes and perceptions, because what that leads to is writing people off and assuming they can't benefit from treatment. Therapeutic nihilism. In fact, if you look at the data, most older people will say, I do not live with life-limiting long-term conditions. That's really important. Yes, they may have a long-term condition, they may have 2 or 3 of them, but they get out and do the things they want to do. And in my parents' case, that's walking around the Great Ormond, going to a lot of theatre and so forth. And, but as long as they can do what they want to do, it's not life-limiting. Older people in both Europe and North America self-report the highest levels of life satisfaction of any age group apart from late teens. So people in their 70s and 80s are far happier than people, my age group, burdened with all the things that happen to middle-aged people. And most people in their own home, only 5% of the whole population over 65 have statutory social care going in. Okay? So most people are not living in care homes, they're not in hospital beds. And as an acute hospital doctor, you can get a very distorted perception because we're seeing often the sickest and frailest older people. GPs will have a different take on it. The other thing is this economic burden story. There's reports from Ireland and the UK, the Sternberg report I've picked out here. If you put in grandparenting, unpaid caring, contributions to the economy through spending, capital wealth and so forth, older people are not necessarily a drain at all, but can make a net contribution to the economy. So we've got to move away from the ageist narrative. But I mentioned about inequalities. Now, Public Health England have a map of premature deaths. And as I say, it's bad news for Mancunians like me because we die young, not as young as Glaswegians, but pretty young, right? But 75 is the cutoff for preventable mortality. So it's people dying before 75. But if people are going to live 2 decades at the age of 65, there's a story about what happens beyond 65, isn't there? So what we've got here for men and women along indices of multiple deprivation is your absolute life expectancy at 65, and then your disability-free or healthy life expectancy. You only have to sit in the lobby of, say, Salford Royal and then compare it to, I don't know, where's a posh hospital nearby, Macclesfield or somewhere by comparison, you will see writ large the difference, okay? So there's very big inequalities in people's absolute and disability-free life expectancy at 65. So there's a lot of interest about what you can do around engagement, self-efficacy, well-being, exercise, housing, and so forth to reduce those inequalities. So it's not all bad news. As I say, lots of happy, healthy older people getting on with their lives and not necessarily skydiving or ballroom dancing. But we've also got to be realistic. There are ideologues out there, okay? And the ideologues are, the medical model's all wrong. You doctors just want to do people. You want to over-medicalise people. It should all be about prevention and well-being. And there's a bit of a reality deficit there because people will get sick and they will come to hospital and they will need healthcare. And there's no point wishing them away. And you'd be amazed the amount of magical thinking that goes on. Like Simon Stevens said on a platform next to me, the NHS chief exec, he said, within my lifetime, we can close all the care homes down if we just invest in new technologies. It's not going to be happening, is it? So we have to look at the downside. And this is one of my favourite graphs. This is from the Scottish School of Primary Care study. This is 3.4 million people in central Scotland. Looking at the GP records, how many long-term medical conditions do people live with as they age, okay? And you can see by the time you're over 75, most people will have 4 or 5 things wrong with them. Now, as a hospital geriatrician where I'm kind of reverse cherry-picking the frailest people I can find, our problem lists go on for a page of A4 when we're on the ward rounds, okay? So it's the norm for people, if you look at GP records, and there's an English database called Symphony that has quite similar findings. Now, from the same study, they've picked out 10 long-term medical conditions there, and they've said, how many people with one of these conditions just have that condition? You know, like that on the, you get your atlas and you want to know what's the drive from Manchester to Norwich and Norwich to Liverpool and stuff. I've picked out one there, which is only 18% of people with obstructive airways disease just have obstructive airways disease, okay? Now, people in the room, GPs aren't allowed to answer this, but anyone want to tell me what the average length of a GP consultation is in England? 8 minutes, yeah. So there's a bit of a standing joke about only one symptom at a time, please. Now, the GPs have got this, and they realise they need to re-provision primary care, but general practice has a huge workforce crisis. And if you read the King's Fund website last week, they had a great thing about a day in the life of a GP. Whatever your right-wing journalists will say when they're having a go, GPs are having 60 or 70 patient contacts a day, and their workload has doubled over the past 2 decades with no increase in workforce. So they realise they need to do something different for people with multimorbidity, but an 8-minute consultation isn't fit for purpose. And as a hospital doctor, there are expert generalists who are geriatricians, casualty doctors, acute internal physicians, but organ specialist doctor. But what people want is a whole-stay clinician. They want one person to coordinate their care. And this illustrates the problem perfectly, really. And it's a paradox of modern medicine for you to think about, is the weight of evidence and research has grown exponentially. So when I was a medical registrar in the early 90s, I could manage people pretty much off what was up there on my training. If you have an asthma attack, if you have a diabetic emergency, you want to go straight to the expert because you're going to do better under their care. But if you've got 5 different comorbidities, you don't really bounce around, do you? So that's a really important graph. And then this drives polypharmacy. Most drug trials are based around younger people than the representative patient population. The average new onset heart failure patient is a 77-year-old woman. The average person in the drug trials is a 59-year-old man, for instance. So, of course, the evidence base around the drugs is based around people who are not typical of the people taking the drugs. And single disease thinking, single disease incentives, single disease specialties drive, and we're better at expert generalism here than most countries, but they drive polypharmacy. Now, it's about appropriate polypharmacy. If you've had a heart attack, it's quite right you're on 3 or 4 pills, and you will have seen the studies this week about people not having enough treatment. But if you look there in Scotland, and it's got worse since then, something like 10% of people over 65 are on 10 or more medications. In nursing homes, the median number of meds per resident is 9, and half of them are completely unnecessary. Right, dementia, very important. Dementia travels with people, and we're not going to solve the problem by wishing it away. The press are very interesting about this, aren't they? Miracle, it was in the paper today on one of the new scan may detect dementia. They're obsessed with a cure. Well, there's no cure for dementia on the horizon. There's no mass prevention on the horizon. Yes, there's things we can do to modify the risk and help people live better with it, but that is the stark reality. And although dementia prevalence in men has gone down recently because of lifestyle factors, if you're a woman over 80, 1 in 4 women will have dementia, 1 in 5 men. That's a fact, Jack, and that will accompany them. So we have to make sure that services are not just age-proof, but dementia-proof as well. You may have seen a rather nasty journalist called James Dellingpole in the Sunday Times 2 weeks ago, who complained grievously about his trip to hospital because they dared to put a man with dementia in the bed next to him, and a yardie who'd been stabbed with a bottle in the other bed. And I tweeted to him and I said, James, what was it? Shock horror as journalists discover hospitals contain sick people. And he wrote back and he said, there should be special places for those. I said, no, there should be special places for people like you, mate, But that's the reality. People with dementia pitch up in large numbers. And then frailty, I don't want to bore people with the nuances around frailty. If I'm going to grossly simplify things, there are 2 schools of thought about this broadly. There's a researcher called Linda Fried who says there's a frailty phenotype, and that's people who you can recognize them when you see them. They have slow walking speed, they fatigue easily, they have muscle weakness. There's a famous paper called The Grim Reaper Doesn't Walk Faster Than 4 kilometers an hour, because you can just get people up and see how long it takes them to walk 0.8. You watch David Attenborough, he is getting a bit frail actually. Muscle weakness, you slow up, you know it when you see it. The problem with the frailty phenotype is it's not routinely recorded on GP information systems, though. The other school of thought is it's about an accumulation of long-term conditions, and I'll show you some data in a minute about that. So by the time you've accumulated a number of different deficits, you're running into frailty, and you've got poor functional reserve. So Andy Clegg, who's he'd be a good person to get to do this talk, actually, Andy Clegg, senior lecturer over at Leeds, did a great review about frailty in the Lancet, which is not behind the paywall. Frailty, a clinical review. The doctors here will know what I'm talking about here. You routinely see 45-year-old women who come in on call with a urine infection, and they present with a fever and pain in their kidneys, right? They do not present to hospital because they've become confused or they've fallen over or they can no longer cope at home because they've got lots of reserve. Frail people are just about above that coping and not coping line, okay? So a small insult, if you're frail, will knock you right over. A puff of dust will blow you over. Crucially, you'll see there, people often don't get back to baseline. And if you talk about, say, delirium, acute confusion, every time people get acutely confused, they often won't get back to where they were before. Difficult with a relative sometimes because the relative will say, well, my dad He was sent to the community hospital 18 months ago, and he did the stairs when he left. And what they're not quite picking up is they're on that trajectory of decline, improvement, but not back to baseline, decline, improvement, but not back to baseline. So people who are frail are just about able to cope, and a puff of dust blows them over. Now, Sir Bernard Isaacs, who was the professor of geriatric medicine at Birmingham University, coined the term the geriatric giants, which was falls, immobility, incontinence, and confusion. And it was how old people who are frail present. And of course, it's not an atypical presentation, as the medical textbooks would have you believe. It's a typical presentation for people who are frail, and people who are frail are the biggest users of health and care services now. And this is how people who are frail present to hospital. Not quite thriving, not quite coping, not quite right. They fall over. You may not know this, but falls account for 40% of all the ambulance call-outs in people over 65 to their own homes. Falls account for more bed days than heart attack, stroke and heart failure combined. And it's usually a manifestation of frailty, okay? People come in immobile. Sudden worsening of mobility is a red flag for frailty. And the interesting thing is, because, I talked about therapeutic nihilism, if a 50-year-old goes off their legs suddenly, oh my goodness, they've got spinal cord compression, they've got multiple sclerosis, we must do something. An 85-year-old goes off their legs suddenly, and often they're just written off. They write themselves off. No one is ageist as an old person sometimes. It's my age, doctor. No, it's not. So they present with immobility, they present with acute confusion, delirium, very scary. Because you come in and you are paranoid, you're hallucinating, very hard to explain to people's families because it's totally counterintuitive that just because dad has got a urine infection, he's gone completely off his trolley and he's saying all bizarre, delusional things. But delirium is very common. 1 in 8 beds in general hospitals has someone with delirium in at any one time, okay? And we cause it. And I'm going to show you an animation I wrote at the end. We cause delirium because we lose people's glasses, we lose their hearing aids, we put them in a rammed full, overcrowded A&E department, we move them to the acute medical unit where it's noisy, then we move them again to a home ward, maybe they get moved another time, we don't give them enough to drink, and so forth. We cause it. Fluctuating disability, and then medication side effects. I've shown you the polypharmacy. People who are frail, even a bit of codeine for the pain will precipitate a crisis sometimes. So, I stopped being the National Clinical Director in the Department of Health in 2012, 2013. John Young, who's one of my absolute heroes in geriatric medicine, has just retired. And Martin Vernon, who's Manchester through and through, he was at Wythenshawe and now he's here at MRI, is the new NCD. But John Young's big thing he did, which has been transformational, is this electronic frailty index. And if you read Age and Aging this month, free to air, there's a paper by Andy Clegg and John Young about the frailty index, okay? And what you do is you use the GP record system to construct a frailty score. And there are 3 national codes now for general practice: mild, moderate, and severe frailty, okay? And this is a population distribution. Now you'll see there's about equal numbers, give or take, of completely fit older people. This is for over 65s and people with mild frailty. The mildly frail do not need to be over-medicalised. And there are schemes in places like Cornwall. Get them doing more, get them volunteer, get them engaged, reduce the social isolation, because you end up in a vicious cycle very quickly of disuse atrophy, don't you? You stop going out, you stop using public transport, you just stop engaging with people, you get no sunlight, you get no vitamin D, your muscles get weaker. So those mildly frail people, it's about helping them to help themselves quite often, and age-friendly communities. The housing story is very interesting because we're not designing anywhere enough housing units that are fit for people to move into as they age. And so they end up with disabling houses. We can talk about that if you want. Moderate frailty, 20% of people over 65. And you can, in deprived areas, get frailty in people under 65. Now, I spent a year as a casualty officer at Manchester Royal Infirmary, and I remember probably the roughest trade of all was from Beswick for some reason. It's emblazoned on me from 20 odd years ago. Beswick, if you saw that on the casualty card, you knew you were heading for trouble. I don't know if that's still the case, maybe it's been gentrified now. But you can imagine even in the Manchester area the difference between Hale Barnes and Beswick, for argument's sake. But 7% of people over 65 are frail, and that has very significant implications. And this is, so John Young and his team on primary care data in England, on existing primary care data, on over 200,000 people. And this is a paper in Age and Aging, which I think is one of the most important papers in geriatric medicine. And what I want to draw your attention to is how incredibly predictive it is of poor outcomes, okay? If you're severely frail, You can see there what you call the odds ratios for the non-researchers. That's basically 5.94, you're 6 times more likely than Joe Public to end up in a care home than a non-frail person. You go down that column on severe frailty in yellow, you're 4.5 times more likely to end up in hospital. You're 5 times more likely to die. And I've been at sessions all day today in Liverpool about end-of-life care and advanced planning. It's very interesting about at what point in their life older people or their families want to talk about planning for the future. But if you've got severe frailty, you should be having the conversation, really. So it's highly predictive of service use. And the argument from John and the NHS England team is the mildly frail, it's about helping people help themselves. Moderate frailty, it's about good primary care, really. It's what primary care should be doing for people if it didn't have a workforce crisis, and is doing for people, but maybe not enough of them at the moment. So there's a lot of, have you all heard of something called the House of Care? It's worth looking at the House of Care and the Coalition for Collaborative Care. And it's all about moving the way we do healthcare to supported self-management. As somebody said, the doctors need to get off pedestals and the patients need to get off their knees, or we want the doctor to be the guide on the side, not the sage on the stage, you know. Ironic considering where I am. But helping people manage their own conditions better to the extent that they want to. But then the severely frail, and I haven't got a slide about this, but what geriatricians do, and we all know the G word is off-putting. We've had endless existential angst about the G word. Comprehensive geriatric assessment is biopsychosocial, holistic stuff. You don't just do the medical stuff. You look at function, you look at rehab, you look at housing, you look at family relations. If you do that for people, when they arrive in hospital, they are about 25% more likely to be alive and in their own home a year later. It works, okay? And that's what we, as geriatricians, focus on. We're the biggest medical specialty in the college, but there are not enough of us to see everyone. It's just going to advance here. Hold on. Right. So what all this means for health and care services, I think any Scots in the audience will know how bad Scotty's Scottish accent was, of course. I won't even try. I'm a Mancunian and he's gone a bit posh. But you remember he used to say, Captain, we have a problem. And we do have a problem because older people with frailty and complex needs are core business. Whether you like that businessy language or not, I don't know, core customers, core service users. Anyone who's training in health and social care this year, it says 2015 there, but 2016, is training with the youngest group of people they're ever going to meet, okay? And people haven't realized it yet, but for most of it, geriatric obstetrics may be coming next because there was a 71-year-old in the paper today who'd given birth, wasn't there, you know? But core business, so when you get, you've put me on the geriatric ward, doctor. No, this is what acute medical units look like. This is what general medical wards look like, okay? So older people with complex needs and frailty are absolutely core business. And I'm not sure our values and priorities have caught up with that modern reality, really. We've got to gear up systems and services for people who use them. But it won't have escaped your attention. There's a huge financial crisis in healthcare at the moment. You will have seen the reportage of it's become like comical Ali in the Iraq War or Mugabe's press officer, hasn't it? Everybody knows that there's insufficient money, and people are just in denial about it in the government, you know? They were saying in Parliament, 8.6 billion savings from acute hospitals over the next 5 years. It's just unrealisable, you know? It's not going to happen. But if you look at where the money's being spent, you won't get it right without getting the care of older people right. So there you go, in acute care, the spend on people over 85 versus every other age group, okay? If you follow the money, get the care of older people right if you're going to solve system problems. And if you look at the NHS Constitution and its technical annex, these are what you call age cost curves, okay? They're looking at future projections for consumption of resource. And you can see there, I've picked the one for primary care, but it'd look the same for mental health or secondary care. Most of the growth in expenditure is going to be about older people and especially the oldest old. Who comes to casualty? Well, I know people watch TV programs where it's all young people knocked off motorbikes and the helicopter ambulance people. This is who comes to casualties. This is from a study by Quality Watch, which is Nuffield Trust and Health Foundation. And as you look up through the age bars there, the turquoise is people with multiple long-term conditions. So what this graph shows is the biggest group of customers are over 50, and the people over 50 have long-term conditions. Walk through any A&E department, you'll see that, okay? Of course, you get younger people with trauma, but that's who's coming into casualty. And this is who's in hospital beds. So this is hospital bed days by age. And by the way, the data I'm showing here are 5 years old. It would be even more stark now. Right at the top there, that's bed days occupied by people over 85. And below that, bed days occupied by people 75 to 84. A quarter of all the bed days in the NHS are occupied by people over 80, and if you're in, say, Cornwall or Devon or Southport, where I used to go as a kid, my granddad would take us out to Southport, you'd never see the sea, it was about a mile away. Southport, retirement community, okay? And here's a real, I like my killer stats, only 5% of all hospital episodes are in people who stay longer than 3 weeks, but they account for 41% of all the bed days in the NHS. And these are old people who are stuck because they've had 3 or 4 admissions to hospital, and by the time it's the 5th one, they're on that frailty trajectory, they ain't going to get home. And it's fine ideologically talking about care closer to home, but they often don't want to go home, or the relatives don't want them to go home. And we've got to have a different offer for those people because hospitals are dangerous places, as I'll show you in a minute. The Royal College of Physicians belatedly got this agenda. Hospitals on the edge. Our hospitals are struggling to cope with the challenge of an aging population. We've lost a third of the beds. And again, the ideologues who don't like acute hospitals, think about this. England has the fewest hospital beds per thousand of the population of any country in the whole OECD. We're about 2.4 beds per thousand if you separate England out from the UK, okay? We're not conspicuously overbedded, whatever people say. We have a third the beds that Germany does or France does, for instance, okay? So hospitals are rammed full, they're under pressure, and the people coming in, as the college got, have these complex comorbidities. 1 in 4 hospital beds right now in England has a person with dementia in that bed. 1 in 4, okay? So that's who comes in. Delayed transfers of care. We don't like to talk about bed blocking, and I do challenge people whenever they said bed blocking or bed blockers. But these are the official figures from England. They got to the lowest. I mean, I'm not making a party political point here, but Labour did increase NHS funding year on year for 11 consecutive years. If you look at 2011, first year of the coalition government, the delayed transfers of care started to rise because they'd slashed social care. And the reason they'd slashed social care is because you can't touch health care because it's sacrosanct, but you can cut social care and there won't be a mass public outcry on the whole. And this is what's happened. So you can see delayed transfers of care on the rise, and my lived experience is this is what's happening. And by the way, it's not just social care. Intermediate care, community health services, is now taking an average of 8 days in England to get from hospital into one of those step-down services. So delays are on the rise. And intermediate care, this is a brilliant document if you're interested in rehab outside hospital. The intermediate care audit looks at half the providers in England. When I say intermediate care, that might be rehab in your own home. It might be rehab in a community hospital, which there aren't too many of in the Greater Manchester area. It tends to be more home-based. It might be to keep you out of hospital. It might be to get you out of hospital sooner. But the intermediate care audit, median age of the patients is 82, and it's largely about frail people. We only have about half the capacity we'd like. I hope there's nobody from KPMG or Ernst & Young or McKinsey or Deloitte in here, but they will write these reports saying a third of people in hospital beds don't need to be there, and of course that's quite right. But that's hypothetical, because the capacity has to be there in these services, and it ain't there, okay? And then you will have seen, it's the Ombudsman's report that I was speaking to today, has highlighted some really poor experiences, but there's lots of stuff about discharge from hospital. The report Safely Home is a great report from Health Watch England, lots of individual stories from older people and their carers, and it's very even-handed, that report, because it talks about people being marooned and stranded, and it talks about people going home before they feel they're ready. Now, the quote I said to Sheila Fogarty on the radio today was the old Nigel Edwards thing that the acute hospital runs on a stopwatch and the community runs on a calendar. So, oh, we like that, we'll use that in the show. But people are marooned and waiting for things to happen as much as they are going home prematurely. RVS, the voluntary sector's role is really important in the care of older people, and it's underplayed, maybe because there's so many different charities in the space. But they did this work called Avoiding Unhappy Returns in Leicestershire, where just by putting in a volunteer befriender when the person went home, they halved readmission rates. Big numbers. Red Cross in my hospital are there till 10 o'clock every night getting people back home when official transport won't get them back home. But anyway, there's lots of stuff about readmissions and poorly planned discharges. Care homes. The British Geriatric Society has done loads of work about care homes. There are 430,000 people in care homes in the 4 nations of the UK in about 16,000 different facilities, okay? Some in big chains, some standalone enterprises. There are 3 times as many people in care homes at any one time as there are in hospital. So Simon Stevens is, even in very age-friendly countries like Holland, like Norway, they have care homes. And I met Norway's oldest man, who's 109. And he talked about his experiences in perfect English, even though it's not his first language. And he said, when I got to 100, I decided it was time to go into a care home. And I picked the one with the biggest car park so I could have visitors. So people come into care homes, and the point is they're very, very sick. You don't go in there for fun. Most of them have dementia. Most of them on multiple medication. They have immobility. They have incontinence. So there's a false dichotomy here between the medical model and the dignified, person-centered, nice environment thing. If they don't get adequate medical help, if you're in pain, if you have incontinence, if you're falling over, if you're immobile avoidably, then you're going to do badly. So they have very complex care needs, and they're being admitted to hospital in big numbers. This is a report. If you read my BMJ column, it's all free to air. I've written a lot about this, about admission from care homes. This is just from Quality Watch again. So that's the outer donut is the whole over 75 population. And the red is your emergency admission risk. And then the inner donut is the care home population. No surprise, you might say, that care home residents are far more likely to be admitted to hospital, but often that admission adds no value, and a third of them die when they come in because they're being sent in for want of proper end-of-life care and support quite frequently, and then they're staying too long. And then the thing, you've heard a lot of talk about integration. Now, Chris Ham's my boss at the King's Fund, and he's made integration his life's work. And the point is, other people do benefit from integrated, coordinated services. Of course they do. But it's largely older people that are bouncing around using multiple services. And I won't do it now, but something I often do is I get people in the audience to say, if you're a health and care professional, put your hand up if you've had to coordinate the care for an older relative of your own. Half of them put their hand up. Keep your hand up if you've found it really difficult, even though you're in the job. Nobody ever puts their hands down. And so my argument is, if it's really hard for us when we know our way around the system, God help everybody else. People describe fragmented, poorly coordinated care. So how we need to change. The workforce needs to be fit for purpose. It needs to have the right values, the right skills, and it needs to be deployed in the right part of the system. And we're a long way off that at the moment. We need to reflect the people we're actually going to be looking after for a living. I mean, I've got to do mandatory child protection training, but there's no mandatory dementia awareness training in the same way, for instance, And I never have any dealings with children because I look after very old people. So, we've got to shift that, the training balance. We need to move towards a person-centered approach, not a disease-centered approach. There's a National Voices report called Person-Centered Coordinated Care, which I commend you to read. It's full of I statements developed by interaction with older people and, with patients in general. When I have my medication changed, I want to know why. I want to know what signs to look out for. I want to know who to contact. Anybody had any experience with the Salford Older Persons Reference Group? Yeah, they're brilliant, aren't they? The Mature Persons Reference Group, and they've got Salford Sally. And so you've got able Sally needs a bit of help, Sally needs a bit more help, Sally, and needs a lot of help, Sally. Now that's getting things in lay terms, isn't it? But that's what they want, person-centered coordinated care, a shift more towards prevention and well-being. As long as we haven't got magical thinking and over-promising, we need clinical guidelines to respect the fact that people have multimorbidity. And frailty is a long-term condition in its own right, and we've got a way of identifying it and a way of coding it now. Now, what I'm going to show you, and I apologise if some of you have seen this before, patient stories really matter because people are full of platitudinous BS, aren't they, really? Michael O'Donnell, the famous medical writer, described a platitude as something that you could define by saying the obverse and see how ridiculous it sounded. So you think about the 6 C's of nursing: compassion, communication. Well, nobody's going to have a value statement that says we want compassion-free care with piss-poor communication, are they really? So, and too often people under pressure retreat into their professional silos, and I'm seeing this now. Let's do anything we can to delay the continuing care assessment another week because we won't have to spend the money. Not person-centered. So I keep bringing it back to let's talk about real-life people and what happens to them to really focus your mind. So Mrs. Andrews is only 4 minutes long. It's free on YouTube. And there is a Mrs. Andrews Mark II in which I stop the animation and talk about what happens. But when I play this to people who are health and care professionals, they are embarrassed in their laughter at it because they know we do this to people, okay? So when you watch it, just think about what could have happened differently.
My name is June Andrews. I'm 84. This is the story of my trip to hospital. It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward.
Never a good move.
After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening and Arthur was becoming stressed, concerned and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
It's funny, I've watched that several times, and I wrote it, and I still get a bit tearful watching it because it's all too true, isn't it? You know, I mean, obviously this doesn't happen to everybody, but the point is too much of this still goes on. And if you're interested in videos, there's a great thing called Barbara's Story from St Thomas's about what it's like through the patient's eye coming into hospital with dementia on the trolley with all these unfamiliar people speaking to her. The King's Fund has an animation called Sam's Story, and that's Sam in the middle there. All about what it's a bit South Parky, the animation though. But so in my paper for the King's Fund, and this is where I'm going to finish, I put together a scheme of what are the indivisible, like the primary colours, you know, the prime numbers around services that wrap around the older person in the centre, helping people age well and stay well. That's the primary care, public health, well-being thing. Helping them live with long-term conditions, much the same as any person at any age group. when they do have those complex comorbidities, how we support them to live well. And the first one sits in public health largely, and the next two are largely in primary care with some overlap. When people are frail, they decompensate quickly, so something has to happen quickly. If it doesn't happen quickly, they'll end up in hospital. So they need a rapid, credible response in their own home. They will come into hospital, you can't wish them away, and if you've had a stroke or you have a hip fracture or whatever, you need to be in hospital for a spell. The issue is they stay too long, so you need that, manage them well, don't make them worse like we did with Mrs. Andrews. And then when you do get them out, they need proper post-acute rehab, because I showed you the graph where if you're frail, you don't get back to baseline unless you make adequate post-acute illness and injury rehab key business, which is why therapists are so important. People do badly. If they do go into long-term care, and there's plenty you can do to keep people away from nursing homes with extra care housing, with rehab, with adaptations, when they do go in, make it as dignified and person-centered as possible, because you're going in there for the end of your life. People last 15 months on average once they've gone into a care home. And end-of-life care is important at every stage, and the important thing is that shift towards prevention and well-being and away from reactive crisis management, and that shift towards joined-up care. I know there are some people writing things down. I think all the slides and the presentation will be available, by the way. So you think about Mrs. Andrews there, she was on some blood pressure pills. Why was she on them? She didn't need them all. She'd started to fall. What was anybody doing about it? Had they sought any help? Her memory was starting to go. Did anybody know about that? When she came in, had a crisis, she could have been got home quickly, but she was put into the hospital sausage factory and moved repeatedly. I sometimes want to get people a rock band tour t-shirt with the name of all the wards they've been on, and then I'm afraid clinicians are bad for black humour like that, I'm sorry, but when she goes home, a poor husband still doesn't have a proper answer about why she's confused or why she's at falls risk, and so on and so forth. So if you put the person in the middle, these real life patient stories, it focuses the minds of people away from their silos towards what they ought to be doing. And that's the final thing, really. The golden baton of blame. I was doing some work with Dudley hospitals because I go all around the country helping hospitals with their care pathways. And one of these people said, oh yes, the golden baton of blame, which was basically, it's not us, it's them. You've got to stop doing that and actually think, what can we do within our gift? And this is the Edmonton police force. When I was over there doing a talk, they had a women's street safety campaign called Walk a Mile in Her Shoes. And so these muscular coppers were all wearing kind of silver stilettos, and they is well shamed, aren't they? Yeah. So, but the point is, unless you've actually been that GP in the person's house on a Friday night with a daughter standing over you saying, Mum's got to go in, unless you've been with that minimum wage, care assistant in the residential home who's getting the ambulance to come out, you shouldn't be judging people. You should be seeking to understand what their particular pressures are. So that's where I'll stop. That's Fuja Singh, the oldest marathon runner in the world, who did his last marathon at 102. And he has a running club called Sikhs in the City. And he attributes his longevity to ginger tea and curry, if you're interested. And apparently Fuja has the bone density of a 35-year-old. That's Buster Martin, who died recently. He used to do 3 days a week at Pimlico Plumbers, even though he was 100. But he was disqualified from a marathon for lying about his age, so he could be older than Fuja. So even older people can be rascally. Anyway, thank you very much.